Good morning, everyone. I'm Mary Greeley. I'm president of the Healthcare Leadership Council. The Healthcare Leadership Council is a coalition of CEOs representing all sectors of healthcare, but we're also a very enthusiastic member of the Better Medicare Alliance. So our members who are payers as well as providers and health information technology companies are great partners with the Better Medicare Alliance. So we have a wonderful panel for you today, and we're going to just jump right into it. And I'd like to start with having each of our great panelists introduce themselves and tell us just a little bit about your organizations. So Valinda, why don't we start with you?
Sure. Thank you, Mary. So I'm Valinda Rutledge. I'm the Senior Vice President for Federal Affairs for America's Physician Group. We're an association that has about 350 practices that either employ or contract with close to 200,000 physicians. Where our association's mission is a commitment to capitated and integrated and delegated care, and many of our members are in risk-based contracts with MA plans and have been in those for decades. So we're a very big supporter and believer in the MA value.
Great. Ian, why don't we hear from you?
Sure. Thanks, Mary. My name is Ian Tong. I'm an internist. I'm the chief medical officer at Doctor on Demand, and I'm a clinical assistant professor at Stanford Medical School. Joined Doctor on Demand 7.5 years ago as really a 50-state medical practice, virtual medical practice that exists in the cloud. And what we've done that's a little bit different is we've employed our practice. So we have employed board certified internists, emergency physicians, family practitioners, pediatricians. Also, we have a behavioral health practice with psychiatrists and doctoral level psychologists. And what we've done is we've enabled patients to connect to those clinicians within about 5 to 7 minute wait time on the medical practice side, and often a 3 to 5 day wait time in the behavioral health practice side. Really all in an effort to improve access to high quality care through a telemedicine platform. I think the one last other thing that I'll just say in the brief intro is that Doctor on Demand, about 2 years ago, we launched the nation's first virtual primary care health plan in partnership with Humana. And really you're seeing, I think now, just some of the utility of that practice. This is certainly not the way that we wanted to get here, but we had an early belief that the country needed better access to high quality care, and we really thought we had the tools, the infrastructure, and the technology to be able to enable that through a platform like ours. Thanks for having me.
Thank you. Anne.
Yes, good morning. Anne Mond Johnson. I'm the CEO of the American Telemedicine Association. The ATA represents over 400 organizations that are really a diverse collection of players in the industry, including delivery systems such as Intermountain and Avera eCare, payers including Humana, and academic medical centers, pediatric facilities, and then a range of solution providers, including organizations like Amwell and Teladoc Health, to organizations that are more enablers of delivery systems such as Zipnosis and BrightMD, organizations that are more AI forward, like Babylon Health and Conversa Health, to organizations that are asynchronous in their orientation, like Hims and Hers and Row and NERCS and GoodRx. And then we also have a number of organizations that are very focused on remote monitoring, including Vivify and Livongo. And then finally, we have a series of members who are what I call the enablers, the ones who believe that high water floats all boats, including Intel, HP, Sony, Microsoft, AWS. And we're all united in this vision that we're here to ensure that people get care where and when they need it, that when they do, they know it's safe, effective, and appropriate, while enabling clinicians to do more good for more people. So very happy to be on this panel and join Ian and Valinda and you, Mary. Thank you.
Well, thank you. And it's a great description. And I noticed we share a lot of joint members as well. So interesting, the cross-pollination here.
Mhm.
Well, I think everyone would be interested in hearing what have been your experiences for your organization or for your members of your organization during the whole COVID-19 pandemic. What challenges did you or they face? And what are some of the successes that you've had? Um, so Ian, why don't we start with you? I feel like you're frontline in all of this.
Yeah, certainly, and and I think it is an interesting story. If you think about early telemedicine practices, like a doctor on demand, we are delivering clinical services. Most of us were doing most of that work synchronously, doctor and patient or clinician and patient together at the same time in the same virtual space, if you will, solving a clinical problem. But a lot of that was really felt more like a niche. It was something that existed within the healthcare system, or only part of the country had heard of telemedicine or was aware of it. And what I would say has happened now is, because there's been such a large disruption in our normal way of doing things, and that's not just in healthcare. We know that that's education and everything that we do. But that large disruption, really shifted the paradigm, if you will. And so all of a sudden, within days of the beginning of this global pandemic, the White House was mentioning telemedicine on a daily basis, and the news was mentioning it on a daily basis. And so all of a sudden, the awareness shifted to where, I think almost every American has become aware of telemedicine. I'll joke inside our office and just say, no number of Super Bowl ads could have brought us this level, the level of awareness that COVID-19 had. But obviously, it's a tragic way to get here. But I think, but I'm actually really glad that all of these services and these integrations existed. So we saw about a 400% increase in demand for our services. I'm sure this is, and Anne can probably speak to this, probably consistent across all of the large telemedicine practices. Again, 400% increase in demand and services. We were able to meet that, and I think that should be part of the story. It was a challenge for 4 weeks, but within 4 weeks, telemedicine was able to scale to where we were back to our normal wait time. And I think that's an important part of the sort of the learnings for the nation in terms of what happens when you have an existing telemedicine infrastructure. You can very quickly adjust to disasters, global pandemics, or just any other disruption, in our normal flow and our normal place of care. So just one thing that I'll say that we did in response, well, a number of things we did in response, but just a couple of them. So we had to figure out how to triage patients quickly. And so we were able to put that in the app within the first few days and have a way of risk assessing and triaging patients and then helping direct them. We also built, our waiting room filled up. So we were able to build a sort of a digital doorman, if you will, that was essentially being able to control the flow of patients and being able to calculate, well, what is the wait time? How soon will this patient be seen? And so if we thought that we could see them within a reasonable, responsible amount of time, we would allow them in the waiting room. But if we thought the wait would be too long, we were able to use our digital tools to triage them and let them know that they probably need to, they're better off seeking care elsewhere at this exact moment that they're trying to enter into the app. So there were a lot of things like that I would say we hadn't had to really deal with that overwhelming demand. And so the team really came together to do it. And I think the digital tools themselves, we learned that they work very well.
Great. Valinda, how about your members, and how many of them are engaged in this previously, currently? What experiences have they had during this period?
Yeah, so most of our members, when I discussed it with them, they said, that they had very limited, if no, experience in terms of telehealth prior to COVID. So there was a steep learning curve, some of them actually in the areas of the country in which the COVID cases rose very quickly. They got as high as 70 or 80% of their volume actually transitioned very quickly into telehealth. Now they're back down to about 15 to 20% of their volume staying in a virtual visit. And so they're anticipating to remain at that level probably post epidemic. Now, I will say in terms of the obstacles, you can put the obstacles and challenges that they experienced in 3 buckets. The first one was the virtual health, the telehealth, the change in how we're delivering care, just getting used to that process. The second one was technical, and it was at the physician level, the provider level, as well as the patient level. Many of our patients did not understand how to go on the video, and we actually needed to send people out to help them or figure out how to assist them in terms of getting on. But it was also the physicians getting comfortable with the platform that they were using. And what I heard is that the bandwidth issue was both at the provider and the patient level. We always assumed that the bandwidth issue and the stability of the internet is at the patient level, but in some cases, it was actually at the provider level that they were struggling with. And the third, which really surprised me, and I hadn't thought of this at the beginning, was equipment at home. Being able to do some of the virtual health visits and the patient not having a blood pressure cuff. So they had to figure out how to send that blood pressure cuff or a scale to the patient. So putting it in those three categories in terms of the care redesign, the technical issues, and the equipment were the biggest obstacles.
So Anne, your members obviously are at the forefront of all of this. What did they learn during this experience, and what stories of challenges have you heard, as well as the success side of it?
Sure. So I think it's very similar to what Valinda and Ian have commented on. From the delivery system perspective, there was a whole swath of members who were able to scale up very quickly, literally with hundreds, if not thousands, of physicians. And that was because they had primed for this. They were thinking in terms of this, but instead of it taking 10 months or 10 weeks, it happened in 10 hours in some instances. So the scaling up quickly went very well for some delivery systems and not as smoothly for others. The second thing I'd comment on is what Ian pointed to, which is the whole role of async and the ability to interact using assessments, questionnaires, chats, chatbots. I think that what those proved was, number one, that it was a way for the delivery systems to scale the response because they were just getting absolutely inundated. And it was a way to really help people understand what they could do to support themselves or how they might stay at home or quarantine in place. And I thought it was really important that the ability of these async tools to really help organizations deal with their broader community and interact with them was really, it was amazing. The innovation that went on. I mean, the changes, I suspect it was true at Doctor On Demand, the iterations that you were able to offer with a digital mobile app was fantastic in a very short period of time. And that was it was a reflection of the innovation. And I think it's safe to say that in many ways, technology saved the healthcare system from imploding. So I think that that's another lesson learned. The other thing I think our members learned is that, as Valinda pointed out, there were a lot of hiccups. There were hiccups in terms of getting up to speed from the physician's perspective, from the consumer's perspective. But what is remarkable is how consistently, not across the board, obviously there's some hiccups along the way, but at the end, people were very, very comfortable. They thought it was a good experience by and large, both consumers and clinicians. So this whole idea of we needed the pandemic to get people to try it because they didn't try it, and now they've tried it and actually like it. So that's the other thing we learned.
Yeah, actually, I think there's a couple good points, Mary, if I could jump in on that Anne made. One is the experience, the clinician experience and the patient experience, especially for those who had never tried this before. I think Valinda made the great point that it was difficult in the beginning because if you didn't have the infrastructure or you hadn't set this up in your home, even as a clinician, right, you sort of took for granted that your internet did everything you needed it to do until you tried to ask your internet to give you a really good connection where you could actually see a patient and respond and examine them. And so I think that the having of that platform and being able to establish that connection, I think what you're seeing and what Anne's talking about partially is that the doctors who were able to do that realized all of a sudden, actually, this does not damage or harm the doctor-patient relationship in the way that I might have been biased or thought that it would. And I would include myself in that group. We may have just lost Mary, but I'll keep telling you guys because I think we have everybody else.
Okay, yeah.
I've seen this happen. I've actually seen this happen before on a Zoom panel before, so I'm sure she'll be back in a second. But so anyway, so I think that ability to form that relationship is there. We actually published a paper a couple of months ago in a Mayo Clinic Proceedings, the Quality and Innovation Journal, that looked at we really looked at the comments that patients make when they do rate 5 stars. And the number one thing that they actually comment on actually is the relationship or establishing rapport. So I thought that was interesting. And so, Anne, you brought up the asynchronous component. And so we are definitely getting, we've gotten more into async during COVID. Dr. On Demand has, and the ability to chat and then also do voice visits with our patients. And I think the ability to use the async is a great, I think it's an easier leap or easier to use when you know the patient already. Like, I think that in cases where, I know people are using it in different ways, so it might be a great way to engage and start the relationship too. But I think I can see those modalities having, more utility and more ability to resolve, resolve cases if that doctor is using it in their own practice and knows that patient already, would be my guess.
So I want to make a comment on what you said to reinforce it. What we found out that afterwards, when many of our practices surveyed our patients, one, incredible high satisfaction, as you said, they loved it. But what was interesting was right at the beginning, they felt very connected to their provider. And for, almost 100% of it, it was an established relationship that they had. The provider at first was so uncomfortable with the technical aspects of it that they were focused on that and wasn't aware yet of the human connectivity that the patients were experiencing. Only when some of the patient satisfaction results came in, they were starting to see, I love it. I feel connected to my physician. When I go to see him at the doctor's office, a lot of times he's distracted by people coming in, or he's distracted by putting information into the EMR. And so what happens when they had these calls, it was one-on-one. Like, I'm sitting here now and I can see both Anne and Ian at the same time. And so when you are in person, sometimes you're not having that eye-to-eye contact, but when you're doing a video visit, you are. So immediately the patients responded to that human connectivity. It took the physicians some time to recognize what was happening, because unfortunately they were focused on, I'm trying to work with this new platform and getting a good visit out of this. And so once they got comfortable with the technical, they started realizing the value of it.
Yeah, great.
And there's Mary.
He flew back in on one of those planes.
So we had a power outage at my condominium, so my apologies.
Oh my
We'll get
gosh.
back on track here. So I hope you enjoyed talking among yourselves for a few moments.
We had a pretty good discussion around we talked about asynchronous and using that through certain modalities, and then also how it played out through like a doctor on demand and the ability to establish doctor-patient relationship. We primarily use video visits, but we use other modalities as well. And then Valinda just was talking about just sort of doctors who were totally new to telemedicine and just how they interacted with the different tools and and patient experience. So it's great.
Both very positive.
Yeah.
Okay.
Yeah.
So it sounds like all of you expect that we will see a very much increased level, even after the pandemic, of the use of these telehealth services. Is that pretty much your impression, that both the providers as well as their patients are really taking to this experience and finding that it works well?
So I think if I could jump in, I think we're all tracking the same claims data on Medicare beneficiaries, for example, where less than 1% of their visits were with telehealth pre-pandemic. It went up to just over 50% at the height. We're all very familiar with week 15. It's emblazoned on our foreheads. And then now it's between 15 and 20%, as Ian mentioned. And I think the interesting thing now will be as the data starts to surface on, with behavioral health, for example, the no-show rates going down as people, use the virtual services more and more. I think we're also seeing a lot happening with remote monitoring. And I think that at the end of the day, it's going to be much more of a hybrid approach. So what you're doing at Doctor on Demand, I think, is a little bit of that, figuring out which modality is working. And probably Valinda's seeing it in their practices also. I think that the big switch from the consumer's perspective is finally the system met them where they are, which is the ultimate in consumerism. And that's really what people want, and found that they could be safe at home. They could still be monitored at home. And so, yes, I hope it continues to go up. It continues to be a greater proportion because we can use the technology to do more things for more people.
Yeah. I think that, in these moments when you have something bad that happens, right, this global pandemic being the catalyst, there are silver linings. And one of the silver linings is we have the opportunity now to take data. And I think CMS and the Medicare Advantage programs will have so much more data. Before COVID, we had a lot of biased or preconceived notions about seniors' ability to engage over a mobile platform, their ability to download, to use an application such, that's digital, and to interact, and probably biased of whether they would be able to establish a relationship. And I think we now have data that suggests, that all those questions can be answered. And in some cases, they may even be preferred. And especially, I think it's worth making the point or stressing the point that on the behavioral health side, I mean, this is a place where within brick and mortar practice, we have a lot of difficulty with supply and demand matching on the with behavioral health in this country. We have a shortage of behavioral health clinicians, but we have a very efficient model that we see now with telemental health. And I think it not only helps on the efficiency side and the access side, but it actually probably reduces the stigma. The ability to be able to see a behavioral health clinician from your home in your own environment, it has to be much more comfortable than going and sitting in a waiting room with with strangers while you wait for the doctor to be available. So I think that I think people are going to walk away from this with that new data, that new experience in their minds, and say, there's a different way that I can actually connect with my doctor. And my guess is they'll ask, their existing clinician, right, Valinda? I mean, I'm sure a lot of these doctors are going to be asked, can I start to do some of this remotely now?
Yes.
I'd really like to do that. It works.
Right.
It works better for me for these types of problems.
Right. Now, some of the data that some of our practices have gathered. Well, first of all, we have found that, as Ian just said, behavioral health, it looks like it's a little bit different than the primary care visits. Primary care visits have went down to 15 to 20%. But in some of our practices, they're saying when you talk of the behavioral health visit, it actually is remaining at 80%. So they think that behavioral health may actually continue to stay well above 70%, at least above 60%. So it is not dropped like we have seen the primary care visits. So when we look at the utilization of it, I think sometimes we have to subdivide it into a primary care visit, a specialty visit, and then look at the behavioral health. Some of the other data that our practices are keeping track of, because I'm constantly asking them for this data. So when I have conversations at CMS or on the Hill, I'm able to articulate very clearly in terms of the value of it. One, they're looking at patient satisfaction, and that has been through the roof. A second is hospitalization. And they've actually found, as Ian has said, a combination of the video visits with in-person visit actually creates a synergy that they're able to see a dramatic decrease in hospitalization, particularly for some of the very, very chronically ill. The top 10% in terms of chronic diseases, they have 3 or more chronic diseases, that they're seeing that the combination of the modalities actually creates some synergistic. So as Ayn has said, and Anne, we're actually changing how we're delivering care. It's not going to be a separate modality. It's going to be part of the care that we render to our patients.
Well, I
Amen
think
to
you make
that.
a very good point. We're hearing from some of our plan members that they are seeing actually some better efficiencies, cost effectiveness. You point to reduction in hospitalization, so that we may actually see some cost savings coming out of this, even if we are seeing higher utilization of these visits. Anne, what are you hearing in terms of data from your members?
Yeah, likewise, in terms of behavioral health sticking, I mean, there's a lot of variation that you'll see across specialties. So behavioral health sticking, I think one of the interesting admonitions to build on what Valinda said is let's not digitize the bad. And so it's really this honest reexamination of how we're doing things, which I think is really refreshing. The other is that with the cost savings we have with some of our members, at least one of our members who's very, very focused on skilled nursing facilities, reducing the readmission rates back to the hospital, keeping people safe in place within their nursing facility. So that's another area that we're pointing to and really looking at some potential cost savings. And that's just going to continue as we start looking at more and more of the data.
Well, it sounds like we will not, as the CMS Administrator Seema Verma said yesterday in announcing expansion of telemedicine in Medicaid, Medicare fee-for-service, and the CHIP program, that we're not going to be putting the genie back in the bottle. But I think the question is right now, we have this wonderful waiver authority that CMS and HHS are using during the public health emergency. I think the big question is what happens when the public health emergency ends? So are each of you taking a look at, all right, what are the laws or regulations that would need to be changed in order to continue this good work? And are you focusing on that?
I'm sure Anne is. I mean, this is a big one, I would think, for her, but it's a big one for us too. So I won't try to answer all of it because I'll leave plenty of meat on the bone for Anne and Valinda to think about it. But I'll go back to the data point that I was making. We have clear data that we've talked about in terms of, patients love it, doctors love it. I actually think I think as we get more in the data, we will see that this is probably going to, COVID is ending some careers and closing practices, but telemedicine could reopen those practices and actually extend careers. And we've already seen that in our practice. So I would just say more, that's just anecdotal, but more data will show and study of this will show, I'm certain that what I've just said will end up being true. I love that CMS came out and Director Verma said, we're not going back, the genie's out of the bottle. This is where we should have been 10 years ago, to be just to be, I guess a little more provocative. I mean, we've had the technological infrastructure to have this capability for well over a decade, really. And if you think about the first smartphone did not have a camera on it, but as soon as they started putting the camera on that phone, you started to have the ability to be able to conduct video visits and examine patients remotely and so on. And so, in my prior life, I worked at the VA Palo Alto healthcare system where we had a more traditional hub and spoke system. We required patients with the same CMS originating site requirement to come into a clinic space, so the patient would always have to travel that last mile to get in person in front of a health technician, and then the health technician would connect them on a big cart remotely to a doctor that maybe was 90 miles away or something like that. So I did a lot of work like that 12 years ago. In the system, and we had that capability, but the originating site, to me, that requires patients to go to a healthcare facility to then access telemedicine makes absolutely no sense, Congress has to act on that. They have to eliminate that, and that's just one that we, that'll have to happen. Otherwise, they will be trying. Otherwise, regulation will require that they try to fit that genie back in the bottle, and they'll have to undo that. They'll have to act.
Yeah, I think HR 7663, which is the originating site, that's absolutely essential. And I would say a couple other things is the federally qualified health centers and the rural health centers, their ability to provide telehealth and be reimbursed for that is another thing that we're advocating for. A third is to continue for CMS to continue to cover additional telehealth services and then remote patient monitoring as well. But I will say that what was interesting in the pandemic, in addition to everything that has to happen at the federal level to make sure we don't fall off this proverbial cliff, is what has to be done at the state level as well. So we have this patchwork of a lot of different state regulations, and it's going to be really essential that we work to remove the friction associated with providing services across state lines, because some of the wait times that happened with some organizations were because there was this backlog of people trying to get licensed in a particular state. And so you saw those wait times drop dramatically as licensure occurred.
Yeah, I know we had
the other thing about is compensation. I would love to hear what you guys think about the compensation piece, because I think an important piece here also is the fact that Medicare said, well, we'll compensate for a voice visit or a video visit the same. And that was also not necessarily the case before. So I think that's just to be very, very real about it. I mean, doctors, have to, they're going to want to make a living. They're going to want to be compensated. So I don't think they're against this type of care, but there needs to be some sort of model for the compensation.
In response to what Ann and Ian has said, totally agree with both of them in terms of what needs to be changed at the congressional level. CMS, is certainly open to expansion, but they've been very clear how they are limited of their agency authority to make these changes. In my conversations on Capitol Hill, I think that there's several congressional leaders that are very interested in making those changes in terms of allowing expansion at the urban area, modifying the originating site, as Ian has said. But I think we've got some obstacles ahead of us. A couple of them are, number one, CBO continues to feel that with expansion of it, there will be a higher cost, and in their estimation of almost an overutilization of it that will drive additional cost. And so I think it is very important for all of us when we are having conversations, not only at the CMS level, but even more important at the congressional level, to show that you can't take it in isolation, that you actually have to take it as a care redesign and look at it across the continuum and not just look at telehealth in isolation. The second part is not only the cost, but they are very concerned about fraud, and they continue to talk about what will be guardrails that will be needed. And the conversations I've had with them in terms of, I understand the need to have guardrails, but let's not make them so cumbersome that it actually will negate the value of it. And so there are many guardrails that some of the congressional leaders would like to see if it is expanded. So I think that hopefully we will see some changes in telehealth going forward, but I suspect it's not going to be wholesale. It's going to be more of incremental. They're going to want to start out slow to assess, to see if there is an additional cost to, particularly with the Medicare fee-for-service population, to have an increase in utilization with it. And they're also concerned about fraud aspects of it. So as leaders in these, both at the plan level and the provider level, I think when we have these conversations, we have to come to those discussions with what are appropriate guide rails that we could live with, that we think can continue to allow us to utilize this modality as an integral part of care redesign.
Well, you raised some really important issues. And I think my biggest fear is there's no quicker way to kill innovation by imposing micromanagement in this area. And I'd be curious, do you feel that the Medicare Advantage plans have a little more flexibility here than if we're looking at the typical fee for service and the views of fraud and abuse in that area?
Absolutely. I mean, absolutely. I think everyone's very much more open to allow as much flexibility. And I think CMS went ahead and then right at the beginning to issue those flexibilities for the plans with that. In my conversations, they continue to be very open to that. But I think when you move into a Medicare fee-for-service, then they get very concerned about it. I've also heard from commercial plans, they're also concerned. And so some of them are pulling back on no co-pays and how many telehealth visits you can have and et cetera. So definitely, Mary, you are correct. From an MA perspective, we have a lot more flexibility, and maybe that'll allow us to take those learnings and allow the other parts of the patients that we serve to have that same capability.
But hasn't that been true all along in your experiences with telehealth, that it just fit better in terms of the value proposition in a value-based environment than it did a fee-for-service environment? At least that's something that I learned when I started the organization 2 years ago. So I think that that's important. I will point out on the fraud, waste, and abuse, the ATA was one of 3 convening organizations along with NCQA and the Alliance we put together a telehealth task force, policy task force. And the subgroup that we were responsible for focused on fraud, waste, and abuse, or program integrity, which is code for fraud, waste, and abuse, and patient safety. And what we recommended was that, not to put in place guardrails that are unique to telehealth. In other words, there is technology available. The system already is very robust in terms of detecting fraud, and that you didn't need something specific to telehealth. You don't have to treat it as a sideshow. So that was one of the recommendations that we were very strong on and very unanimous in consensus.
Yeah, I mean, I think also there are Medicare Advantage definitely has the flexibility. I would go back to my VA experience and say that that's a vertically integrated healthcare system, right? They're the payer and the provider, and so you can just look at how they use telemedicine. So there's templates and models for how telemedicine has been used to provide the good and be able to monitor and eliminate, the fraud or some of the waste. In the VA, we would say it was waste, right, or it was unnecessary. Because there wasn't, physicians or others weren't necessarily benefiting or cashing in on overutilization of services. So that's automatically governed, I guess, within a VA. But I think that, but we already have in this country some established players in the space who've been working with health plans and are in network and are NCQA accredited, and who already have been audited by numerous large national plans as well as regional plans. And so I think when you look at those plans, if CMS wants to look at that data, I think they'll see that cost savings come out of those visits, especially. Again, I can say more about video visits, especially with the video visits that we have done. This has not been published, but you see very high case resolution rates and low cost. And so, and you don't see unnecessary prescribing of things like antibiotics and, subspecialty, unnecessary subspecialty referrals and things like that. So, and unnecessary procedures, right? Because there's no in-office procedure to do. So for a telemedicine doctor. So anyway, I think the data is there. I think there's been high, regulation and audit around this field already. And so, yeah, it would be a shame if it's stifled by overregulation.
Well, I think something that will be very, very important is how do you take your real world experiences and the data that you're gathering and then bring that to the Capitol Hill arena and members of Congress, and particularly their staff that we already know are looking at this and we'll need that data, as well as to the regulators who seem very supportive of this, but I am sensing a little skepticism, from some folks on the Hill. Now, the opposite of that is we've had members of Congress, and I don't think he'd mind me mentioning his name, but Dr. Burgess from Texas, ranking member on the Energy and Commerce Subcommittee on Health. And a couple of months ago, he said, and it was to a rather large audience, I am here to say that I was wrong. He was a real skeptic about telehealth. He is now fully embracing it. So I think we can get some voices like that to be loud and clear on Capitol Hill, and especially people viewed as fiscal conservatives. That's really going to make a difference. So Anne, what are you finding in terms of Capitol Hill? What resonates with the staffers and members of Congress that you're meeting with and trying to promote this?
Sure. So there have been champions of Congress for quite some time, and telehealth is one of those unusual bipartisan issues that we, quite frankly, are very happy about. So, for example, Representative Thompson and Schweikert are both champions, Doris Mitsui. So I think what we're seeing is a lot of support, and Joe Kvedar, who is a physician and really a leader in the industry, and also the president of the ATA, testified in front of the Senate Health Committee a few weeks ago. And what was interesting in that testimony was that Lamar Alexander opened it by saying, I think we need to get rid of the originating sites. And it's like, yay. So yeah. I think, to Valinda's point, we have to come prepared and we have to have the data. And I think that what has happened historically is that the industry has been a little bit splintered, and what the net effect is small dogs chipping at the heels of people on the Hill. And we have to be a lot more cohesive. And quite frankly, that's part of why we're excited to have such a diverse group of membership and really seek to collaborate as much as possible. So I know one phone call I'm going to make after this is to Valinda and find out what data she has, and to Ian as well. So I think it's going to be really important for us to unite behind this if we're going to keep the momentum going.
Right. No, I think that collaboration is always important. It's very powerful. And there's nothing Congress likes better than being able to divide and conquer. So anytime you can get that collaboration and stronger voice, it makes such a difference. And I think they are eager and desperate for information. So anything quantifiable that can be provided, I think will make a tremendous difference. And of course, CBO will always be a challenge. But again, if you can bring them the data, I think we can really progress in this area.
So I would say, just to point out some things that my co-panelists have mentioned, which is there were a lot of myths that were refuted during the pandemic. One myth was that somehow when you're virtual, you overprescribe antibiotics. Another myth is somehow that telehealth is not personal. It's not an intimate experience. You can't create a relationship or build on one. So I think a lot of these myths, it's up to us to categorize them and again, put it out there that no, it's been proven wrong.
That's good to hear.
My guess though is the other thing is the grounds, like now so many people have actually just tried a visit, both on the physician side and on the patient side. And I think they've now seen it. And I think having that experience is it's very mind opening, just very mind opening for the individual who's never had it. And so that has to help. Now everyone COVID has given us the perfect case study for, well, what if we had flipped our health system on its head and put virtual first and then wrapped around all brick and mortar behind that. There's, you can worry about fraud and abuse, but I would say, tracking everything through a digital platform allows you to eliminate most of that, or at least track it. I mean, I think that fraud and abuse exists in traditional practice as well. And so my argument would be you actually will eliminate, I think, a lot of the incentives for that. And be more efficient if you actually flip the model on its head. And again, COVID-19 has given us an opportunity to look at that data. And I think we're going to see health systems start to produce some of it. Doctor on Demand certainly has. We have a lot of data with our work through plans. But then also these anecdotal stories from individual doctors who, in Texas, the medical board, people who really were just certain about, all the perils of this before. I think it's great to hear that those are the people who are going to sing the merits of this going forward.
Great.
Well, I know Ann mentioned earlier some of the licensure issues. And I know that is cross-state licensure. That's an issue that we worked on. One of our members is AMN, Nurse Staffing Organization, that had thousands of nurses that they were ready to deploy to hotspot areas. And we were all under the misperception that the federal government could just issue an executive order that would waive those barriers, that if they were licensed in one state, they could go anywhere they wanted. And then we quickly and painfully learned that we had to do this on a state-by-state basis. I just wondered, Ian, what your experience was with that, and if you had it pre-pandemic as well as during it.
Well, we had it pre-pandemic. We had already, this was one of our sort of trade secrets, if you will, right, is to know how to break the country up and have a multi-state licensed doctor, and how to do that. Like that was an advantage for us when with the prior requirements. The removal of those requirements, which was the right thing to do for a public health emergency, did allow us to, it allowed us to take what we already knew and just accelerate it, actually, which is why we were able to go for, which is why we could respond within 4 weeks to the 400% demand, whereas that would have been harder for an organization that had never multi-state licensed a doctor. So I think we were able to leverage that pretty well. On the downside, though, right? It is a little bit humbling, which is it means we also though have a lot more competition now, because really it's enabled a lot of different people to say, oh, well, now it's much easier to get a license. But that is what I would say is that's progress, and so you just have to adjust to that. And I welcome, I think it's the right thing to do. It's what our country needs. It's what patients need, and we needed those regulators who the way they would typically do their jobs are to make sure that people are not abusing, making money and making profit by not paying the money to get an additional state license to practice medicine across a state line, right? That is it's a pretty small concern, to be honest with you. And it's a pretty small amount of money, but if you think about what's gained by allowing that doctor to be able to utilize a virtual platform, to be able to, again, cross that state line virtually and be able to provide care to patients that need it, I feel like it's, the moral and ethical benefit far outweighs the concern of whatever they're losing on the fee side. But I would just encourage the folks at the medical boards and so on to make the process easier. I mean, just make it easier to navigate. I don't think anyone would have a problem paying the fees, and they would be more likely to do that if the process was more efficient. And so it's gotten much more efficient. Doctor on Demand, we were able to do multi-state licensure with Medicare because of what they did do. Again, we were able to navigate the state by state. And so, and then because we geolocate patients through their devices, we can always match them to a doctor licensed, or to a doctor in our group that's licensed for that state. So it's a very cool matching problem. The problem with healthcare delivery in this country in many cases is the sorting and matching of doctor and patient when they see the services needed and matching them at the right level. And I think we have a lot of great learnings in terms of how to do that. And again, COVID has given us a great test case to say, well, how would we do it if we lowered some of that regulation and made the process more efficient?
That is good to hear. So I have a question from our audience, Ian, and for all of you, really. We're talking a lot about doctors and physicians here, but are any of you working with other healthcare workers, advanced practice registered nurses? Maybe talk a little bit about that. What does this mean for other providers of healthcare and the role they can play?
Yeah, I'll be brief and just say, absolutely. I'm talking mostly about doctors because that's the bulk of our practice, but absolutely, we have expanded with nurse practitioners, master's level therapists. Again, the increased demand in services has given Doctor on Demand the opportunity to expand the clinician types. And so we we've always believed in a multidisciplinary team in our practice. That we've integrated already the behavioral health and primary care practices. So those doctors work together, huddle together. They use the same electronic medical record, and they have case discussions together. So there's a lot of integration that we've already done, and so so absolutely this is opportunity across the board. I would say at sort of all levels of the healthcare spectrum, whether you're a nurse, a doctor. And one of the things that we do in virtual primary care is we have a care team, and that care team is not made up of doctors. It's made up of pharmacists and diabetes educators, and that's part of our virtual primary care platform that allows us to wrap that virtual care team around the patient. And so it's really, it's working very well. And I think, yeah, this pandemic has really kind of opened people's eyes to the need for that kind of service.
Yeah, several of our practices have actually used dietitians, video visits from dietitians and social workers to actually assess social determinants of health variables, in particular food insecurity. And so they've actually had video visits with the dietitians and social workers. So I totally agree with Ian's comment. It is an entire care team that was using the virtual health, telehealth. It was not just at the provider level.
And I would just comment that, again, there's this expression of enabling clinicians to practice at the top of their license. And for the life of me, I didn't know what that meant for a while, but I have a lot of clarity on it now. And that does mean that we're going to have to really push the whole notion of interstate compacts across the board. Clearly that's been done very, very well with nursing. It's not finished, but it's been done very well. And we have to do more of that. So I think, again, if you think about what existed in the country pre-pandemic, there's an absolute shortage of clinicians, not just in behavioral health, but across the board. And this notion of using technology to just replace a face-to-face visit is inadequate. It's going to sell the whole thing short. We have to use it to reimagine care. And it's going to be more than just the physicians. It's going to be a whole team of clinicians.
Good to hear. Valinda, you touched on the social determinants of health. So we're hearing a lot, and I think we'll certainly be hearing more about that during this summit. But, the areas of transportation, nutrition, physical safety. I wonder if each of you could just comment on how telehealth interacts with those social determinants of health that have become the increasing focus of many healthcare providers and payers.
Well, I'll begin and then I'll turn it over to both Ian and Ann, but certainly almost all of our practices recognize that was an integral part of an issue right from the beginning. So as I said, they really got the dietitians and social workers involved. Many of them looked at their patient populations and they determined what had the highest risk for some of these variables. In particular, they were very concerned about the food. In some cases, if they had contracts with MA plans, they would actually, and was responsible, they would actually deliver some of the food to make sure that those patients had that. It's a little bit more difficult when you're dealing with a Medicare fee-for-service population, and so they tried to make appropriate referrals, but they certainly got the entire care team together. The other thing that they recognized that many of the people that was having problems in terms of from a lodging and a home perspective, they may not have access to the internet. And so they would actually have what's called a drive-up clinic, that the person would come up in a car and be able to access the clinic's hotspot to be able to get their virtual visit. Or if they had no mechanism to do that, the clinic would actually bring out an iPad to the patient to be able to have the care rendered. So they were looking at innovative ways in which they were providing care and addressing some of the social determinants of health issues. Ian and some of your thoughts and what you've seen.
Yeah, I can jump in, and there's a couple things. So if we're thinking about a senior population or a Medicare member over the age of 65, I think a major determinant could be transportation and, just the ability to get to a visit, but also if if you're not facile with Uber or Lyft, you need a family member maybe to lose work, come out, have a day of work that they miss or half a day of work that they miss to help you get to that appointment. And so, I think we've really seen where telemedicine really does address that. So you have a kind of a where you get care, you can now get it from home. So all the transportation determinants and issues there, and also the where of you get care is not in the same place where there might be a COVID positive patient, right? So that's a really important thing for a senior, is to be able to be safe in seeking care and not going to a place of care that's also a site of transmission. So I think that's really important. So that's on the where side, and the how people are getting care. There's it's 24/7. Your people are able, again, from home to connect with the doctor and get a number of services. Either delivered. So medications can certainly be delivered now to their home through these visits. And so I think the last thing I'll just say about this is really important, I think, which is you have parts of our population, because of structural racism, that really aren't going to have great access to internet possibly, and the ability to have broadband speeds. But the reality is, what we see is they actually, though, do have mobile devices. They actually do have a cellular connection. And so I think the ability to have that, and for people outside of healthcare delivery, but people also in telecommunications and so on, being able to respond to events like a coronavirus event, where they're able to maybe lower the cost of data plans and so on, so that those cellular devices are the connectivity, so that it's not a burden, honestly, Valinda, on the doctor's office to have to create a telemedicine infrastructure for their community. That is something that I think large telecommunications companies hopefully are able to do. And Comcast actually, I think, did do some of that, which was really great. So I think, those are the kinds of decisions and leadership things we'd like to see that help address the social determinants for different patients. I crossed a few different ranges there. From seniors is where I started, but also I think, it's there are certain communities, ethnic minority communities that are also going to have challenges here. And so, again, I think the reason why many of us ended up in telemedicine was to help improve access to those populations, rural being the most traditional one. Telemedicine was originally created to help improve access for rural populations, and it was used very heavily in the VA for those populations. So I see this as a tool for eliminating disparities and improving, and addressing those social determinants, no matter what they are, across multiple different populations of patients.
Well,
I think they've said it well.
Well, an excellent point, because I think traditionally people think of telehealth only for rural areas, to improve access to underserved areas. And I think what Ian is focusing on here is we don't have just geographically underserved areas, we also have underserved populations. So, what has been your experience, say, in the urban environment for telehealth services?
Well, that's the use case I usually talk about, honestly, because I started in telemedicine with the VA, but immediately I was obviously thinking, well, no, there's other places where this could be used. So making the service 24/7 was an important one. But the use case that I always would think about is the single parent who has a job from 9 to 5, and so therefore either has to miss work, from between Monday through Friday to attend a doctor's appointment, or has to find a weekend service. And so it's no wonder that people utilize the emergency room or the urgent care. And so that's a system problem and needs a system solution. And we should never point the finger at that single parent who's trying to make their life work and their family work. And so those are, I think we've always had that in mind, and we have seen uptake. And there was actually a recent article that came out saying that Black patients were actually more likely than white patients to engage during COVID. Were more likely to engage telemedicine than white patients, actually. I don't remember who that came out from, if it was Health Affairs or whom it was that published that, but it was an interesting article and not necessarily what some people would have expected to see. For the senior population, actually, we've seen like a 4,000% increase in Medicare Advantage utilization from last year compared to this year. So that's a pretty, so that, that starts with low utilization, but that's, spike in utilization at this point. So I think there's some interesting things happening.
I think the statistics have been staggering in terms of utilization. And I know the CEO of Tivity Health yesterday was talking about silver sneakers, where they had 0 virtual visits, and now it's 300,000 a week. So this exponential growth is just amazing. So any final comments? I think we have about probably 30 seconds.
I would just say that I think we're talking about behavioral health and primary medical care, or primary care, which is where we started, but we're going to see more modalities and subspecialty and more hybrid models coming out as a result of all the experience that we're gaining. And so I know people probably have questions about that, and I would say stay tuned, because you're going to see a lot more case studies and models and data that show where the care can even be better in some cases when it's done remotely.
Great. Well, I think that's a great note to end on. I want to thank all of you for your contributions to what I see as a very patient-centered approach to healthcare, and wish all of you success. So thank you very much.
Thanks, everybody.
Thank you to our great moderator.
Yeah, great job.
Well, thank you.
I survived the attack.
Thanks, everybody.